When you think of a midwife, you might think of someone smiling and holding a baby. Or maybe you think of the classic movie scene where the woman is yelling at her husband and saying, "You did this to me," and somebody is in the distance yelling, "Push!" Or maybe you don't think of anything, and that's okay too. But what we probably don't think of when we think of midwife is trauma. But maybe we should. So don't get me wrong, most aspects of midwifery are beautiful. They're not traumatizing. Most appointments and most births are overwhelmingly positive. But the reality of pregnancy and birth is this: when something goes wrong, it can go really wrong really quickly. Good midwives know how to manage complications, and they know when to transfer care to a higher level. But sometimes it's not enough. As a current midwifery student and someone who has worked in labor and delivery in Uganda, Nepal, Cambodia, and India, I've seen the immediate and the long-term effects of difficult births on midwives and midwife students. Midwives and their clients develop a personal relationship during those 9 months of pregnancy. That relationship makes midwives particularly vulnerable to trauma whenever birth has complications or bad outcome. In this speech, I will explain what secondary trauma and vicarious trauma are, and how midwives and midwife students experience these kinds of distress. So according to Rasmussen University, secondary trauma refers to a response that can occur from witnessing one instance of trauma. So there are many standalone situations where a midwife could experience trauma that was then processed as secondary trauma. The most obvious would be any situation where a baby or a mother dies. But other situations may end up being fine, but can still be traumatizing. Things like a shoulder dystocia, where the baby's shoulder gets stuck on the way out. Things like postpartum hemorrhage, where the bleeding is uncontrollable. Things like an unexpected breech, where baby should be coming head out, but is coming bum out instead. These are all urgent situations that could become life-threatening if not handled properly. These situations could be traumatizing. A 2017 article in the British Journal of Midwifery discusses the way that traumatic events are processed and stored within the brain. This article recommends that midwife students be given a non-judgmental space to process difficult births. When space for debriefing is given, the experiences and memories from that trauma event are given context, and the brain is able to process that memory in a less emotionally charged way. So while secondary trauma is the impact of one event, vicarious trauma is the change that someone experiences when exposed to continuous or consistent trauma. The British Medical Association defines vicarious trauma as a process of change resulting from empathetic engagement with trauma survivors. So most independently practicing midwives have a certain number of due dates that they accept per month before they feel like they're at capacity. Because of the unpredictable nature of birth and the 5-ish week window when a home birth might happen, midwives can only make an estimated guess to spread out the births that they attend. They may go directly from one birth to another. The midwife has to push the first birth out of her mind so that she can show up with her full self for the second birth, because babies come whenever they want to. A 2018 and 2019 in-depth study of 29 midwives in Turkey concluded that traumatic birth has more negative impact on a midwife when the midwife is not able to take time to process the event. It also indicated that in some cases, vicarious trauma changed the way that these midwives practiced midwifery. Experiencing repeated traumatic births resulted in midwives who practiced more defensively and who are more likely to use interventions before appropriate. I personally saw this in India. We did a shift where it felt like every single mother hemorrhaged at some point. After the last delivery, this mother was bleeding a normal and expected amount, but the midwife that worked at the hospital overcorrected and started her on a higher dose of Pitocin, which is what would contract her uterus and stop the bleeding. Her bleeding did stop, and she wasn't hurt by the higher dose, but it was more intervention than what protocol would have deemed appropriate in that circumstance. I've also seen vicarious trauma impact a midwife's love for midwifery. And I've known midwife students who've decided on a different path after difficult births. The word midwife, it means with women. And it's that personal relationship that midwives build with their clients that makes midwifery care so valuable and also makes midwives so vulnerable to secondary and vicarious trauma. Thank you.